Ladies and gentlemen, good afternoon. Okay, so I will speak about automation. Can it help to limit mechanical power? I'm working in France, but I have to disclose that I'm also working part-time for Hamilton Medical. So as mentioned by Luigi, mechanical power is an index that aggregates all the ingredients of the recipe or the components of the mechanical breath, namely the inspiratory pressure, the PEEP, the tidal volume, the flow, the respiratory rate, but also takes into account the lung status. And this is why I think it's interesting, because in the same index, you have the lung status and you have the ventilator settings. And we all know that Wiley results from a lung at risk of Wiley with settings at risk of Wiley. So it's a combination of both. And this study has been already mentioned that if we look retrospectively at a large number of patients, and calculate the mechanical power over the first 24 hours of mechanical ventilation, the mechanical power is related to the outcome of the patient with a sort of threshold between 17 and 19 joules per minute. And we all know that, yes, over a certain energy transmitted to the lung, there is inflammation, there is Wiley, and Wiley increase the risk of mortality. So can automatic mode automation in mechanical ventilation help? I will mention here two ventilation modes. One is adaptive support ventilation. For those of you who are not so comfortable with this mode, you know very well that in mechanical ventilation, we have to set on one side the ventilation parameters, so a combination of tidal volume and rate, the product being the minute volume, and on another side, the oxygenation settings. PEEP and FiO2. ISV is a closed-loop mode that automatically selects the combination of tidal volume and respiratory rate for a given minute volume that is set by the user. How does it work? I will not go into detail, but ISV is based on two physiological principles that have been described a long time ago, the minimum work of breathing and the minimum force of breathing. I will not describe this ugly formula, but just what you need to know is that the tidal volume selected by ISV is is proportional to the static compliance, meaning that if the static compliance of the patient decreases, the ventilator will select a lower tidal volume. Let me just give you an example. If you take a man, 180 centimeter, his projected body weight is 75 kilograms. And if we set a target minute volume at 9 liters per minute, which is conventional for this patient, if the patient has a normal static compliance, let's say 58, and normal resistance for an intubated patient, this will result in a tidal volume that is around 7.2 milliliters per kilogram and a respiratory rate around 17 breaths per minute. And the resulting driving pressure will be 9 centimeters of water. Now, if the same patient with the same ventilator settings decreases compliance to 33, which is what we see usually in an acute ARDS, early onset ARDS, then the ISV mode will decrease automatically the tidal volume to 5.5, which is a decrease of 20 to 25%, and increase the rate to maintain the target tidal volume. And now it will result in a driving pressure of 11 centimeters of water. So you may say, well, but what is the point? If you decrease tidal volume but increase the rate, at the end of the day, the mechanical power will be the same. Well, not really, because if you look at this figure from Gattinoni, from Professor Gattinoni, that was published in the original paper, he described the percentage on the x-axis, the percentage of variation of the main component of the mechanical power versus, on the y-axis, the percentage of variation of the mechanical power. And as you can see, there are 3 lines. The most important components are tidal volume, driving pressure, and flow. Then respiratory rate, which is also important. And PEEP is much less important, meaning that if we increase PEEP, we don't increase that much the mechanical power. So let's go back to the previous example. If ISV automatically decrease the tidal volume by 25% when the static compliance decrease, you see this will be associated with a huge decrease in the mechanical power. But of course, in the same time, ISV will increase the rate by 25%, more or less, and this will increase mechanical power, but the net effect is quite significant. Okay, you see a large decrease in the mechanical power when we adjust according to the respiratory mechanics. And this is how ISV, by selecting the tidal volume and the rate according to the respiratory mechanics, will limit mechanical power continuously. Now let's speak about the second mode, which is called IntelliVent ISV. IntelliVent ISV is based on ISV. It's a full automated mode where all the settings are automatically selected by the ventilator. In IntelliVent ISV, we have 3 different controllers, a ventilation controller that adjusts the target minute volume according to an entitled CO2 target. Then a second controller that is the ISV controller, the same as before, and a third controller that is an oxygenation controller. Now, let's focus on the ventilation controller. How does it work? The user has to set a target entitled CO2. In this example, 36 to 43 millimeter of mercury. The ventilator measures using a mainstream sensor the current or the actual entitled CO2 and compare it to the target. If the entitled CO2 is higher than the target, it will increase minute volume, and the other way around. Now, please focus on the pink line, where you see that the target entitled CO2 is different when the peak pressure increase above 25 centimeters of water. So, by design, this ventilator mode will apply a sort of permissive hypercapnia as soon as the peak pressure is above 25 centimeters of water. What we should do at the bedside, but we don't think about it all the time, or maybe we think about it later, will be applied automatically. And you will see later that by applying permissive hypercapnia, we can reduce the mechanical power. So let's jump to the clinical data. This is a purely prospective observational study, 255 ICU patients, where we did the measurement in the first 24 hours after intubation. And we split this patient in normal lung, COPD, and RDS. And we look at what IntelliVent ISV is doing. The results are the median and interquartile range. And as you can see, in terms of tidal volume, ISV, IntelliVent ISV, select a median around 7 and let's say between 6 and 8 meters per kilogram for the normal lung patient. For COPD patient, a little bit higher, and for RDS, between 5 and 7 meters per kilogram. Now, look at the driving pressure. It's interesting to see that the driving pressure selected or applied by this mode is not different whatever the lung condition. It's always between 8 and 10 centimeters of water. This is the application of the algorithm. And also regarding mechanical power, you can see that whatever the lung condition, the median mechanical power is somewhere between 9 and 12, and we didn't find a patient ventilated with more than 17. Now, if we focus on the subgroup of RDS patients and split in mild, moderate, and severe, the tidal volume was lower for the most severe patient, but again, the driving pressure remains at 9 or 10 in median value for all group of RDS patients, and the driving pressure also is maintained below the threshold. There are some comparative studies. This study was performed in Switzerland during the first wave of COVID. They retrospectively analyzed the patient ventilated for the first 7 days in COVID, and they compared the mechanical power for the patient ventilated in IntelliVent ISV in red with all other modes, conventional mode, in blue. And as you can see, along the first 7 days, it seemed that mechanical power is lower when they use IntelliVent ISV and always below the threshold. There are a couple of other studies. This study was a before-after study, so they include 24 patients ventilated in pressure control, and they activate IntelliVent ISV and look at the different component of the mechanical power. The blue line is ISV, the red line is conventional or pressure control. In terms of tidal volume, there was no difference. In terms of minute volume, it was a little bit lower in ISV, but it was not statistically significant. Driving pressure was not different between the two periods, but here you see that the respiratory rate was much lower when they activate IntelliVent ISV, and this resulted in a decrease in the mechanical power. And this is the permissive hypercapnia concept or rule. A kind of similar study, before-after study, pressure control to IntelliVent ISV, now in 51 passive COVID ARDS patients. In yellow is the conventional mode, in blue the automatic mode, and as you can see, the driving pressure was slightly lower in IntelliVent ISV. It was significant, but the value were not so different. But the respiratory rate was much lower in IntelliVent ISV, and this result again in a lower mechanical power. And finally, the same group of researchers, and I think they did a great contribution to this topic, published recently, and it will be presented tomorrow morning as an abstract form, a randomized control international multicenter crossover trial where they compare 2 periods of 3 hours in conventional and IntelliVent ISV in 96 ICU patients. And they reported again that the mechanical power is lower when we use IntelliVent ISV as compared to conventional, but only in the subgroup of passive patient, while in spontaneous breathing patient, there was no difference. Honestly, I have a problem with mechanical power in spontaneous breathing patient. I mean, of course, we can measure it, but what is the clinical meaning of this? I don't know. So, there are some limitations. It was already mentioned before. There is no prospective study comparing mechanical power. So we may say, yeah, it's nice, automation is limiting mechanical power, but then what is the impact on the outcome? So I don't have definitive answer to this question. I just wanted to show you the result of a pilot study that we finished last year. It was an international randomized controlled trial where the patients were ventilated, randomized to be ventilated either in IntelliVent ISV or in a conventional mode for the full duration of mechanical ventilation. And we record breath by breath, so we were able to assess every component of the mechanical power. And as you can see, in terms of tidal volume, there was absolutely no difference between the two groups. In terms of driving pressure, no difference. In terms of respiratory rate, no difference. If we look only at the passive breath, it seems again that the mechanical power is slightly lower when we use IntelliVent ISV. And I reported the outcome, which of course are not significant given the number of patients, but it seemed that the duration of mechanical ventilation was a little bit shorter in IntelliVent ISV. The number of ventilator-free days were higher, and the number of patients successfully extubated after 28 days were higher, and the mortality seems similar or even a little bit lower. So, of course, this is motivation for us to start big randomized control trial, and one of them is already running. So to conclude, mechanical power is an index about both the lung status and the ventilator settings. And for me, it's a sort of biomarker that is associated with the outcomes. ISV and intelligent ISV by design limit mechanical power. And the good point is that it's with a limited workload for the user, because after we have to do the initial setting, but then we just have to monitor the patient. All the adaptation will be done automatically. There are good clinical results in short-term clinical studies, and we have to wait for the long-term study. And as mentioned previously, do not forget to optimize the lung aeration. What I mean is that these modes are playing with the current lung. But of course, if you can increase the size of the aerated lung by increasing PIP, by recruiting, or by using prone position, you decrease a lot mechanical power. So don't forget it. Thank you very much.
Thank you very much. That is great. Thank you so much. Just maybe quick questions. There are a couple of there and one reflection before we move to a different, slightly different topic. So I was really fascinated to see that the way mechanical power is reduced in this setting using ASV is actually working mainly on the respiratory rate. Rather than the driving pressure, the tidal volume. Whereas many of the clinical trials that we've seen, they tend to focus on the tidal volume rather than the respiratory rate. Do you think that this is something that we should look more in detail about the role of, the respiratory rate rather than necessarily the volume?
Well, I thought that respiratory rate was not relevant in the past, and maybe we have to accept that it is relevant, and that when we set a ventilator, we overventilate most of the time, and we could do the same thing with lower respiratory rate. And my experience with closed loop is that each time you activate a closed loop, you realize that you are doing too much. The same for FiO2. You realize that you can ventilate the patient with lower FiO2 and here a lower respiratory rate. Will it change the outcome? Let's see.
We'll see. Now, there are two quick questions. One is to say how small the patients have to be tested with IntelliVent or to use IntelliVent. Is there a size?
You can go down to, I think, 15 or 20 kilograms. 10. Okay, I have somebody to help me. 10 kilograms.
So we should be okay. And the other one is something about safety. So whether this mode could be dangerous, for example, in a way that if there is sudden mucus plugging or atelectasis, this might go unnoticed. So any sort of safety tips there?
Yeah, exactly. As usual, the ventilator will adapt to the increase in resistance and will change the way to ventilate the patient. So we have to set some alarms and we still have to monitor the patient. Otherwise, it could be unrecognized, but I'm afraid that the same event could be also unrecognized in conventional. We have to be careful about that, yes.
Fantastic. Well, thank you so much once again.